Hello everybody, for those that don't know me, my name's Faye, I'm the Campaigns and Comms Manager at Endometriosis UK, and today we're joined by Liza Ball. Liza, would you mind just introducing yourself quickly?
Hello, my name's Liza. I am a doctor at the Royal London Hospital, and there I do endometriosis work, which means I see women in the clinic in normal times, and I do surgery for endometriosis, and that is particularly focused on women who have very severe endometriosis, which means I often work together with bowel surgeons and pain specialists.
Great, well thank you so much for joining us, Liza. We got loads of questions, as you can imagine, on our social media channels, but perhaps first you could just explain exactly what endometriosis is.
Yes, endometriosis is a little bit of a weird disease, and it shows itself oftentimes in pain, and oftentimes it is pain around period time. So that could be severe period pain. It could be bowel pain during periods, or pain when emptying bladder during periods, and it often shows itself in painful sex. Oftentimes it's pain during sex that is deep inside the body. But there are many other phases of endometriosis, and that is something that can be a challenge for doctors to help make the right diagnosis. Now, if we look at what actually causes endometriosis, so first of all, if we imagine that the womb, or the medical word, the uterus, is like a little space, and it has a little inner space which expands into big space during pregnancy, but outside pregnancy it's a little space that is lined with cells that you can imagine like wallpaper. So these cells get changed every month with the period. So these cells, we call them endometrial cells. They make a period every month. Now, what happens in endometriosis, that these cells that should be lining the womb are dispersed. They're in the wrong place. They can be around the ovaries, so deep inside the body. They can get stuck onto the bowels. They can be at the very top of the vagina, and very rarely they can affect the lungs. So basically, Mother Nature has mislaid cells, and what they're doing on a monthly basis, they are producing a microperiod wherever they sit in the body. Now, this causes pain, and this is through inflammation. And when, as a doctor, you look at these displaced cells, you sometimes see little blood blisters. They also cause scarring, and what they love to do is they love to stick things together. So they like to stick things together that Mother Nature hasn't designed to be stuck together. For instance, the ovaries are floating relatively freely in the body, but when endometriosis is happening, these ovaries are oftentimes stuck towards the back of the uterus, and that can also affect the tubes and the bowel. So you can imagine it a little bit like super glue, loves to stick things together. Now, when things in the body can't move freely, together with the inflammation, that is what we think is responsible for the pain that people suffer with endometriosis.
And how is it caused? Do we know how it's caused?
Well, that's a good question. There are two big theories, and I'll just go a little bit into these theories. So there is one idea that's been around for many years, where it's thought that some of the period blood, not all the period blood comes out of the vagina during a period. Some of the blood gets sort of backed up through the fallopian tubes into the body. Now, within this period blood, there are cells from the lining of the womb. You remember what we described as wallpaper. And these cells, they are still alive, and they are thought to plaster themselves to parts of the inner body, the ovary, the bowel, as we said before. This old theory has then been sort of refined by newer findings, where it's now clear that many women have this menstruation that partially goes inside the body, but not everyone has endometriosis. And it is now thought that there's a gap in the immune system. And if you think of the immune cells as being the policemen of the body, they don't clear away these mislaid endometriosis cells. So in women who have that gap in their immune system, these cells persist. Now, this is one theory, and the doctors call it retrograde menstruation, which means period going basically inside the body, wrong way. Now, the other theory is that even from when we are embryos, some of these endometriosis cells are just being mislaid in different parts of the body. As I said, in rare cases, they can be in the chest, so in the lungs. In other cases, they can be even inside the wall of the womb, and this is often thought to be basically a design fault in this cell makeup of the body. And as I said, Mother Nature mislaid cells that should be lining the womb, but these cells are now in different parts of the body. And then every time a period happens, these cells follow the call of nature because they are designed to make a period, and that's what they do, even if they are in the wrong place.
No, thank you for explaining that. And how is it diagnosed?
Well, the first line of diagnosis is just basically the woman with the complaints telling their story. This is a really important part, because as a doctor, when you listen to a patient, you can often recognize a pattern. And we even teach our medical students to listen out for a combination of complaints that could help us make the diagnosis. The symptoms we are listening out for is the period pain, painful sex, and we inquire about fertility, because that could be affected by endometriosis, and then other things that could be including painful bowel movement, defeat, fatigue. So once we, as doctors, we hear this combination of complaints, we can already look into making the diagnosis. Oftentimes in the first line, we look at an ultrasound scan. Now, an ultrasound scan can find pointers to endometriosis, but it often can't see endometriosis itself. So it's a bit like when you go inside the woods and you look for animals leaving footprints in the wood. So you see that endometriosis was there, although you cannot see endometriosis directly. So on an ultrasound scan, we would be looking out for cysts on the ovaries, and with the ultrasound probe, the ultrasound practitioner may also be able to move the ovaries a little bit to see if they are stuck by endometriosis or mobile.
And do you have any tips for anyone that might be going to the doctor for the first time? We often get reports of people having to go to the doctors several times before they're referred to secondary care. Do you have any tips on how people can make the most out of their first appointment?
I think it's really important to come back to the first step when it comes to telling the story. In order for a doctor to sort of get the red flag of this client might be dealing with endometriosis, we do need the information about severe period pain and painful sex. And of course, I understand it's not easy to raise these private issues with a doctor you might not have seen before, but without that information, it is near impossible for a doctor to zoom into the right diagnosis. So prior to seeing a doctor, it might be valuable to do something called a symptom diary, where you chart your pain and also chart your periods, so that it can be worked out whether the pain is related to the time around the period, which is a very strong pointer towards endometriosis.
Yeah, no, that's a really helpful tip. Thanks, Liza. And we average diagnosis is an average of 7.5 years. Do you know why it does take so long on average to be diagnosed?
Yes, I have a few patient stories that I was told over the years, and often I hear themes around always seeing a different doctor, or the doctor not being able to listen properly. So, for instance, some clients have described how they complained of period pain, and they felt that the doctor didn't see that period pain as a genuine problem that warranted further investigation, and described it as something that one had to put up with as a woman. And then I can understand if the client doesn't feel empowered to then talk about the painful sex, because then and trust is very difficult to establish when one doesn't feel well listened to. But for the doctor, it's then impossible to make the right diagnosis, because the painful sex symptom doesn't get mentioned. And it's oftentimes these two things together that are a very strong pointer to endometriosis. The other thing about endometriosis is that in the initial stages of treatment, period pain that is there for other reasons, and I think we'll touch on that a little later, gets treated with painkillers and similar medication to what endometriosis gets treated, and in both cases the complaints get better. So because the treatment actually covers a large range of period pain, it is sometimes left at that without going deeper into finding what is actually causing the period pain.
Thank you. No, that's really, really helpful. We also had quite a few questions from people who are under the age of 18. So we had a 16-year-old get in touch with us and ask whether she's too young to have a laparoscopy to be definitively diagnosed with endometriosis. Is there an age limit on people having laparoscopies? And if people are being told that they are too young, what would your advice to them be in terms of getting a diagnosis and also getting the treatment that they need to help them?
That is a very, very good question, and the answer has several layers. A very, very common reason for period pain, especially in young people, is not necessarily endometriosis, but it is having very high levels of a blood chemical called prostaglandin. And prostaglandin is a pain mediator. So people with a lot of prostaglandin in their blood around period time have severe period pain. And this is called primary period pain or primary dysmenorrhea. And it can start very early on. It's very common in teenagers. So this prostaglandin mediated period pain is not necessarily endometriosis. And the best treatment for this prostaglandin type period pain is to take medication that blocks the prostaglandins, and the medication is from the family of ibuprofen and aspirin. So these are fantastic for period pain that is linked to high levels of prostaglandin. Now, these women, girls and women who just have the high levels of prostaglandin, the whole anatomy of the body, the architecture would be completely normal, and there would not be endometriosis sticking things together as discussed before. And then some of these women have period pain from when they're teenagers, later on find out that they have endometriosis. Many years ago, it was thought endometriosis cannot exist in teenagers, but since then, we've had some studies showing that endometriosis can exist in teenagers. And sometimes endometriosis stays the same, or it can even go away. We haven't really talked about how to make a diagnosis over and above the ultrasound scan, but one way of making a diagnosis, and it's what we call the gold standard of making the diagnosis, so a very good way of making diagnosis, is a laparoscopy or keyhole surgery. So with that technique, which is done under general anesthesia, endometriosis can be seen inside the body. Now, the question is whether someone at the age of 16 would want to have such a surgery where a telescope is put inside the belly button and instruments are put inside the vagina. So it's quite an invasive way of finding out about endometriosis. Obviously, if the pain is severe and it doesn't respond to medication, it might require doing a laparoscopy to find out. But someone who has period pain at a young age is also likely to belong to that group of women who have the high levels of prostaglandin, where taking regular ibuprofen would be a very, very good treatment. And it would be not just covering something up, but it would be lowering the prostaglandin. So it would be a proper root cause treatment in that case.
Thank you. And that leads us nicely on to the next section, which is treatment for endometriosis. So what are the main treatments for helping ease the symptoms of endometriosis?
Well, the treatments fall in 3 categories, but the main thing about endometriosis treatment is that it ought to be individualized. So any woman with endometriosis might have different priorities and different pains, and also different response to treatment with regards to effect and side effects. So it's definitely not one size fits all, but it's sort of the art of medicine between the patient and the doctor to find the right treatment at that time of life. Because sometimes treatments are good at one stage and then they are less good at another stage in life. So the categories of treatment, the first treatment is the same treatment as for people who have these high prostaglandin levels, and that would be painkillers, including paracetamol and ibuprofen. And then if the pain is more difficult to control, although one might be taking these on a regular basis, there is also a role of opioids, but they should not be used on a regular basis. Other treatments that can be given in tablet form are treatments that help the body's pain perception, and they are often from a completely different class of drugs. They are sort of ordinarily used for depression or epilepsy, and they can modify the body's perception of pain. The other group of medication that proves very useful, especially when period pain is the main symptom, is hormonal medication to suppress periods. And that could be the standard contraceptive pill, or it could involve a coil that is covered with medication. It could be injections of hormones. So we have a wide range of choices. The main idea here is to put the ovaries to sleep, which means putting the ups and downs of monthly hormones to sleep and making them more even. It might be useful to think that endometriosis basically feeds off the ups and downs of hormones. So endometriosis really loves a fluctuation that happens during the monthly menstrual cycle. What endometriosis doesn't like, where it basically gets starved, is when hormones always have the same level. So then endometriosis oftentimes shrinks and gives less symptoms. And now we come to the third pillar of treatment, which is surgical treatment. In the old days, endometriosis was treated with open surgery, where a big cut was made in the tummy and endometriosis was removed this way. And nowadays, we almost all cases of endometriosis get treated with keyhole surgery or laparoscopy. So laparoscopy is a very interesting concept because it can do two things. So with laparoscopy, the doctors can see inside the body and map out the endometriosis, which helps making the diagnosis. And it is what we call a gold standard, which means that this is a very good way of making sure that endometriosis is present or absent. And it's even improved by removing a piece of endometriosis and sending it to the lab to confirm that the endometriosis is seen under the microscope as well. Now, apart from using laparoscopy to make a diagnosis, it can also be used as part of the treatment. So with laparoscopy, through further little cuts in the wall of the tummy, instruments can be inserted that can help either melting away or even cutting out endometriosis, and also treating the neighbor organs that might have been damaged by endometriosis, including the bladder and the bowel. So we have laparoscopy to make a diagnosis and laparoscopy to carry out treatment. In many cases, these two can be combined as, and then we call it see and treat laparoscopy, which is something very important to bring up with the doctor if you are having a laparoscopy, to clarify, is it a see and treat laparoscopy and what treatment is to be expected. So in summary, we have the family of painkillers for endometriosis. We have hormonal interventions, and then we have surgery.
Do any of them have any long-term side effects that people should be aware of when they're considering what treatment they want to go forward with?
Every person is different. I think when it comes to painkillers, it has now become obvious from studies in America that if painkillers from the opioid family And names could include dihydrocodeine or Vicodin, tramadol. So from this family, these should be used with caution. First of all, they can cause drowsiness and bad constipation, which could make endometriosis pain even worse. But moreover, we are concerned that people might become addicted to opioids, and then these opioids, not only do they cause addiction, they also stop being effective painkillers. So this is something to look out for. Oftentimes when a pain management plan is drawn up, we look at painkillers that can be used on a regular basis and others that ought to be only used for emergencies. And the tablets or painkillers from the opioid family are more reserved for emergencies. And when it comes to hormones, there's a large range of women who respond really well. And they also like the positive side effects of hormones. For instance, some people get very good skin from using estrogen-based contraceptive pills, but other people get breast tenderness or mood side effects, and oftentimes a few different medications have to be checked out, because without trying them, it's very difficult to say how an individual would respond to them. So, for instance, if one contraceptive pill doesn't work for you, another one might work very well from the side effect profile and the pain relief aspects. With regards to surgery, every surgery has its own risks, and the role of sort of in the visit prior to doing the surgery, what happens is it's called an informed consent, and then the doctor outlines an individual profile of likelihood of bleeding, likelihood of inadvertently puncturing the womb or the neighbors of the womb, or infection. So these complications will be detailed prior to planning the operation. And remember, it's always in your rights to ask questions and to also say, you know, I'm not happy to take these risks. Is there something else that can be tried?
Thank you. And I think often people forget that they can actually ask for a second opinion. And if they're not happy with the pathway of care that they're receiving, they can suggest that they want to try other things.
Absolutely. I think it would also be an important thing to bring up prior to surgery, to find out if during the operation it was found that there was a lot of endometriosis. What would the doctor do? Is that a doctor who might have had a few extra years of training to cut out deep endometriosis, or are we dealing with a doctor who's a general gynecologist and is safe to treat smaller, more surface endometriosis, and not the more advanced type of endometriosis? So it is very valuable to have a care plan prior to having the surgery.
Thank you. And we got a lot of questions about hysterectomy being a treatment for endometriosis, and a lot of people asking whether it's a cure.
Yes, it would be lovely if it was a cure. Often it is the last resort, but it's not always a cure. When there's a study showing that when women undergo a hysterectomy for chronic pelvic pain, only half of them get better. Why is that so? There are many aspects of that. the womb or the uterus, which is the organ that is removed during the time of hysterectomy, is not always the reason for the pain. Oftentimes the pain is caused by endometriosis implants that sit a little further away from the womb, and they might still be left behind. Sometimes endometriosis has stuck down things so badly that during surgery the decision is made to only remove part of the womb. This operation is called a subtotal hysterectomy. In these cases, endometriosis can be left behind and still be the reason for pain in the future. The other thing is there's something that is called pain memory. So this is something that we might talk about in another session. But what we think is that what scientists think is that with chronic pain, some of the nervous system pathways have been altered, and even when the original reason for the pain is removed from the body, these pathways continue to exist. Imagine a soldier who has an amputation and then gets phantom pain. So although the limb is gone, the pain is still there. The same can be seen in patients with endometriosis, although they might have had surgery to remove all the endometriosis and even including a hysterectomy, and the phantom pain is still present. So unfortunately, hysterectomy is not the miracle cure. There are some women who have a condition that affects the womb itself, where endometriosis cells are lodged within the wall of the womb. So they're creating a microperiod inside the wall, and I think we're going to talk about that later. However, in this case, the pain is often in the center of the body, and the womb is swollen, tender, angry. So I believe that women who have this condition might be the ones who benefit more from a hysterectomy than women who don't have that condition but have endometriosis. And the womb is just a bystander, the womb itself is healthy. So these women might not benefit much from having a hysterectomy.
And is there a pathway of care for women that have had a hysterectomy?
Well, just prior to having the hysterectomy, we have a pathway that says that if women have endometriosis and require hysterectomy, ideally they should have a keyhole hysterectomy, so a laparoscopic hysterectomy, because with the laparoscope, which is a telescope that gets passed through the cut in the belly button, the things inside the body can be magnified, and endometriosis implants can be found more easily than doing the traditional open or abdominal hysterectomy. And it's stipulated that during the time of the hysterectomy, all visible endometriosis implants should be removed. Women who have had a hysterectomy but still suffer pain would benefit from something that we call a multidisciplinary team approach, where a group of specialists who have an interest and skills in pain management put their heads together. So that could involve physiotherapists, it could involve a gynecologist, an anaesthetist with an interest in pain management, and then complementary treatments such as acupuncture. It might also be valuable to investigate if there was endometriosis left behind or whether there is scarring, and that can sometimes be achieved with an MRI scan. So pain after hysterectomy is quite a challenging question, and it often requires more than one doctor to get to the bottom of that.
No, thank you for going into that. And I think that's one of the biggest misconceptions with endometriosis is that hysterectomy is a cure when it isn't, and the impact can still be felt for life. So thank you so much for going into that. We just had another couple of questions, if you don't mind. Firstly, are there any large clinical trials for new endometriosis treatments taking place?
Well, at the moment with the COVID-19 crisis, most trials are halted because it is not safe for patients to come into research clinics and give samples and sign agreement forms that they want to take part in the trial. However, there are some interesting trials that are either started or about to be started looking at food and endometriosis. And a particularly interesting one, and I'm looking forward to reading about the results, is using the Mediterranean diet. Now, the Mediterranean diet includes nuts, vegetables, healthy oils, and the idea is that it's full of antioxidants. So indirectly, this study looks into the effect of antioxidants on endometriosis. Then there are two more studies that I'm looking forward to reading the results, and they both concern laparoscopic surgery. It's a little bit like with the hysterectomy. Oftentimes we pin our hopes that laparoscopic surgery for endometriosis may be the miracle cure. But it's not the miracle cure for everyone. We know that about 2 out of 10 women don't get better after surgery. But we understand not enough about what type of person gets better after surgery and what type of person does not get better after surgery. So one trial that is based in Edinburgh is studying whether women who have just a few little spots of endometriosis would benefit from keyhole surgery, or if the few little spots of endometriosis are actually not the reason for the pain. And other reasons might be causing the pain. And then there's another project that I'm involved myself, and that looks at data that's already been created in other studies, and that looks at markers in women, ideally before they have their surgery, to see how likely they are to get better after surgery. So these results will really help to give women good information, evidence-based information prior to surgery, how much hope we can pin on surgery in that particular sort of tailor-made situation, and what to expect from surgery, or if it's unlikely that surgery will be the miracle cure, perhaps try a little bit longer to find a treatment that doesn't involve surgery that can be beneficial.
Thank you. No, that all sounds really interesting, and I'm sure they agree that there definitely needs to be much more research into endometriosis, and there's still so much that we just don't know about the condition. So yeah, no, definitely needs to be more research. And then finally, the final question that we had, which I guess brings us nicely to the end, is what 3 tips would you have for women with endometriosis in terms of managing their pain on a day-to-day basis?
On a day-to-day basis, it can be quite difficult at the moment with the COVID crisis, and the perception that the doctors might not be interested in anyone who has endometriosis or chronic pain, because all the doctors are dealing with patients who are sick with COVID. That's not the case. We worry a lot about our women who have endometriosis, and I think places like Endometriosis UK that provide that networking and peer support are really valuable. because I think it's really important that although people might be in hospital battling for their lives with COVID, we still acknowledge how bad it is to live with chronic pain. And having a buddy or a peer group who understands what you're talking about is really, really valuable. Now we all have a little bit more time on our hands. I think another thing that could be valuable managing endometriosis at home is to learn a relaxation technique. Now, the idea with endometriosis or any type of chronic pain is that the pain system is always on edge. So many people have a higher pulse rate because they're in chronic pain or have a higher blood pressure, and that is caused by the sympathetic nervous system. Now, the sympathetic nervous system can be suppressed by relaxation techniques, and relaxation could mean many things for many people. We could be talking about music, yoga exercises, a bit of jogging, mindfulness meditation or muscle relaxation. All these are available online, and many are available for free. And now that many of us don't have day jobs to go to, a recommitment to learning a new technique can be very, very valuable, because if that sympathetic nervous system, that system that always suffering the pain, is always on edge, if that part of the nervous system is more suppressed, then pain is much, much easier to bear.
Thank you. No, that's so helpful, Liza. And I know you've touched on a couple of times about COVID-19, and you're very kindly going to join us for another session specifically on that, which of course we've had lots of questions on. So thank you so much for joining us today. And also thank you so much for all you and your colleagues in the NHS are doing at this very difficult time. So thank you for joining us.